Thank you so much. I would not take much time because Chandramohan has clearly instructed me to be very precise and brief. Thanks for this privilege and opportunity, even though it's a sponsor session. I'm very glad. Thank you. I will not disappoint you, Chandramohan. But having said that, we have, it's very nice to be speaking after two great medical uncles have spoken. And they're talking about precision oncology, precision medicine, and we're talking about precision surgery. So I'll be very happy to take you through our journey and where we really are today with respect to the role of robotics in colorectal surgery. So I'll skip some of these slides. We have all evolved into the computer-assisted surgery, I would call it, rather than robotic in that sense. It's addition of computers into the OT than anything else. And the advantages, most of you would know for sure that we have the stable camera platform, we have the 7-degree articulation of the instruments, the dexterity is much better, we have the 3D visualization, the motion scaling, tremors filtration is there, the comfort of surgeon sitting and operating. Recently we must have heard in China they did the first telesurgery without even the cable. So through the wireless the surgery was performed. So even as we were discussing about surgeons losing job, probably you will be working from home. You will have the monitor at home and you'll be able to do surgery from home, which is going to be reality for sure. So maybe in the next 10 years. Another advantage that we see in robotics is the fixed third arm retraction. I think that is something that really helps us not to depend too much on the assistant, not just for camera but even for the assistant. So 3D image, filtration of tremors, ergonomics are much better and stable platform to operate on. So what really is the difference when you're operating? So the 3D image, 10 times magnified view is something that really helps us differentiate from what has to be removed from what has to be preserved, especially in colorectal surgeries where you need to give importance to the nerves and take care of the the sympathetic and the parasympathetic sympathetic nerves. So that's where I think the fourth arm is very useful for us. It helps as an excellent first assistant. All the three arms under your control alone, including the camera. So there is less dependency on your assistant. So minimal injury to the neighboring structures is what I can say. The endorist helps us to maneuver the instruments much better in pelvis so that you're able to even minimize the energy kind of injury to the nerves. So the endorist does help us. And if you see here, I think there's some issue. Yeah, okay, great. So I think we have already heard this morning about this great man, Healed, who has really brought into us the importance of total misrectal excision with recurrence rates less than 5%. So we know about the quality of the TME. The reason I'm mentioning this is the quality of TME is much better in robotic surgery compared to even laparoscopy. So these are the metrics. I will not, I'll quickly skip them, but important is to know the grade, the circumferential radial margin, look at the nerve preservation, lymph nodal yield, and also the outcomes. So the data today morning we had an amazing debate between the open and the laparoscopic arm with respect to the data available. So I'll skip these slides, but the classic trial did say that the circumferential margin was high, for the laparoscopic arm. So that's where I think the operating time was more cases were converted into open. That's where you saw the outcomes were not that good. So does robotic have an edge in such a setting? I think if you look at the data, the conversion rates are significantly less in robotic arm compared to the laparoscopic arm, even if you have looked at the meta-analysis of the 4 randomized trials. So complications are comparable, but the time to recovery bowel function is much superior in robotic arm. So even the 5-year follow-up data of the classic trial also significantly said the outcomes are much worse for those people whom we had to do a conversion into open surgery, irrespective of the surgeon's experience. So the challenge in rectal cancer surgery, we all know there is a difficulty in insufflation, limited exposure, especially male pelvis, very difficult, bulky momentum, fragile peritoneum, and mesorectum also could be fragile and bulky, narrow pelvis. So that's where I think there is an advantage of robotic surgery. If you look at the various, this is a busy slide, but if you look at the meta-analysis of these 8 studies, one thing that is striking here is that the conversion rates are much less in robotic surgery. So if you look at the other data available, the meta-analysis, there's not much difference with respect respect to lymph nodal yield or the positivity rate, but one thing is for sure, the conversion rates into open are much, much less in robotics. So improved pelvic dissection and better pelvic floor visualization is something that you have with robotic technology. With respect to erectile dysfunction and urinary dysfunction, again, not much of difference for urinary dysfunction, but erectile dysfunction was much better with respect to the robotic. I mean, there was no much of difference, but overall, if you look at the learning curve, I think something that there was a great debate this morning, the steep learning curve for laparoscopy. I think this is something that I can tell that we quickly moved to robotic very early. The learning curve is much, much faster than laparoscopic, and somebody, an open technique translates easier to robotic skills because because of the 3D vision and the fine movements that you can make. So the operative time decreases within the first 20 cases. That's what I call them as the learning curve. So if you look at the laparoscopic colectomy for colon cancer, I think there is enough evidence from COST, Color, and MRC Classic that it is a safe option for colon cancer, but there was still some debate for rectal cancer with respect to the higher circumferential margin and recurrence rate. So the shortfalls of laparoscopy, I think, have given some advantage for robotic surgery, where operative field is small in male. So as I already mentioned before, so I think this is where there is a special advantage of robotic surgery. So technical improvement for the shortcomings of laparoscopy could be met with or could be found in robotic surgery. So this is just a port placement. It varies from which robotic instrument you're using, from SI to XI to the Mantra and the various other robots that are available today. At least we have four in the market today, even in India. So what I would say is that if you look at the precise difference here, you see the kind of magnification, the kind of vision that you have sitting in the comfort of a chair and operating. I think this is the planes you see much better. You're able to sorry, I'm not able to fast forward it, so kindly bear with me. So you can see better, you can do better, and better functional outcomes. You'll be able to see the nerves much better. You'll be able to ligate the IMA very carefully so that there is no damage to the sympathetic nerve trunk. So you see the planes are it's a bloodless surgery. So literally, your short bursts of monopolar current, you're able to do the precise dissection without much of blood loss. So I think planes automatically open up because of the CO2. I think this is as much same in laparoscopy as well. But what is important is if you see here, the dissection of the inferior artery, so you're able to retract with the third arm and then able to open the plane and dissect for the IMA. So better where to use monopolar and how precisely you can avoid damage to the nerve trunk. So I think that's where there is an advantage, and definitely this scores better in my own experience as well. So see there, I think the amplification is also significant here in robotic surgery, wherein a little bit of blood loss would also actually destroy the field. So you need to be very meticulous with respect to your hemostasis. So that's how now the dissection is going on to separate the inferior artery, skeletonize it, and even as you do that, then we apply the clips. We can do robotic clip application, or assistant can help us to put the clip. So that's how the precise dissection can be done. So even if you see here, probably I will also, this is a pretty long video. No, I think, for want of time, I'll skip this. The advantage is that with the present robotic technology, we can even apply the staplers robotically without even depending upon the assistant. So that's the advantage. We can do the rectal transection at right angle or different angles we can do. And of course, today we are also talking about a condition wherein you can remove the specimen transanally without even the need for an incision. So transanal extraction is possible, omitting a mini laparotomy. Of course, single stapling anastomosis can be done. So I think that's the advantage that we find here in TME. The compression with the robotic instrument, exposure much better, and control of the bleeding can be much better controlled. So that's where I think with that I will quickly conclude my talk. The potential advantages what we have with robotics in rectal cancer is basically in male pelvis, precise dissection is possible, better preservation of bladder and sexual function, lesser conversion rates, and rectal transaction under robotic setting is possible. Transcendental extraction is doable. You can also do a very good lateral pelvic lymph node dissection robotically. So the latest trials with respect to laparoscopic open versus robotic, you see the ACOSOG and ROLAR. I think if you look at them, the laparoscopic dissection of rectal cancer was not significantly different open. I think we have seen that today morning as well. But the ROLAR also said that the rate of conversion to open after laparoscopy robotic was not much of a significant difference. That's what they said. But one thing that they found in ROLAR is that in a subgroup analysis in male patients, obese patients, especially with low-lying rectal cancer, definitely there is a potential benefit of robotic surgery. So complete TME again, something that is possible with laparoscopy, but with robotic, they have shown that there is significant difference that it favors robotic surgery. So functional outcomes again, if you see, as I mentioned before, the quality of life, the urinary symptoms, ileus, all of them, there is an advantage with robotic surgery. And with respect to sexual function, there is not much of a discernible variation or changes. So I think at this point of time, many centers across the world are adopting robotics. So a lot of trials are on, and a substantial body of evidence is growing. So we'll soon get to know more about the outcomes and the long-term survival. So if you look at the oncological safety of robotic versus laparoscopy, right colectomy, I think this is where I feel that robotic doesn't have additional advantage than laparoscopy. So for right hemicolectomy, there is not much of a difference, and benefit was not really enough to account for the additional expenses that you incur. So to conclude, robotic surgery is very safe. It's been proven to be feasible, stable field you have, and you have difficult laparoscopic surgery can be much easier with robotics, and the outcomes wise as well, multiple clinical trials, it has been proven to be safe. Probably the next year, this conference, the debate would be between laparoscopy and robotic than between open and laparoscopy. So the addition of robotic surgery is much increasing these days, and there is not much of a benefit in right colectomy, but outcomes are comparable to laparoscopy. It has an edge over other modalities in obese, and where you need to have a difficult pelvic dissection, and for TME it's much better. So minimally invasive telesurgery will be a reality very soon. And as I mentioned before, like Subbu sir mentioned this morning when he was concluding, be open to open surgery. So now you would rather say, no, be open to laparoscopic surgery and embrace technology and robotic surgery. Thank you so much for your patient hearing. Should there be any questions, happy to take.
Thank you, Chinnababu. So I think there is no doubt that India is the biggest place where robotic surgery spread so fast, and at present 4 different type of robots are in the market, and every robot is doing great actually in terms of depending on its cost. And what are the other, I think whole of your thing was rectum. So what are the other organs you prefer?
No, I mean left hemicolectomy and artery resection, all that can be safely done. You're talking about only colorectal, so right hemicolectomy
Do you find any difficulty in doing redocking or something?
Not much. These days, it all depends on the experience of the team. So initially we should take about 20-25 minutes. Now it's less than 5 minutes. Maximum 3 to 5 minutes we can.
I think with the XI, that also you don't need.
Correct. With XI, you can do multi-quadrant surgery can be safely done with XI. So we don't have to really redock.
Any questions? Otherwise, we close. Thank you very much.
Thank you.